Good afternoon, everybody. My name is Ari Parnham, and I'm a consultant urologist at the Christie NHS Foundation Trust, and it's a pleasure to speak to you all today. And it gives me great honour to doing the surmising section for this andrology and genitourinary surgery poster session. And I'll be covering the first eight posters, which can be broadly split into those pertaining to penile prosthesis, Peyronie's disease, miscellaneous benign andrology, and penile cancer. So there are three posters that relate to penile prosthesis. The first of these presented by Mr. Mania. This is the Baus penile prosthesis audit. This is a prospective study over a 3-year period. Data was collected on the Dendrite server system. And what the poster tells us that there's an average of about 357 implants per year. The vast 62% of these were inflatable, the remainder being malleables, although there's a little bit of missing data within that. About 23% of these weren't stated of what type of implant it was. What I think is really remarkable about this, however, is that 60% of these implants were performed in a single centre. Also, the data talks about, or the poster talks about, the number of centres diminishing over the study period of time. So initially there were 28 centres in 2016. This reduced to 13 centres, although the poster doesn't go any further to explain why. And this may be due to data recording, and maybe an attrition in this, and maybe due to regional variances in penile prosthesis commissioning or access. It also talks or looks at pre, intra, and post-operative management. And one of the things I picked up on here is that about 80% of people are using augmentin and gentamicin as their kind of induction antibiotics. There was a paper by Gross et al. In a Journal of Sexual Medicine, which suggested that maybe we should be covering with an antifungal in selected cases, and maybe this isn't necessarily reflected in this data. Complication rate seems sensible, but what I think is also quite interesting is the infection rate. This is 0.47% within 30 days across this group. And if we look at some of the kind of the best data out there, or the kind of the lowest rate, of infection, if you look at Francois Ede, whose infection rate is 0.46%, we are either doing very well, or I suspect more likely in this circumstance is that the data is slightly incomplete to be able to really make a real comment and give a reflection on this. And on a note on that, I think it's reasonable to say also that with the penile prosthesis audit, I think this is something that is going to stay, but what format, I don't really know. The next two posters from the UCLH group focus on complications and difficult implants. The first one is looking at penile necrosis following penile prosthesis. They identified 13 patients. I'm not quite sure what the denominator there is, so I can't give you an incidence rate, but if you look through kind of papers that are available through PubMed, it's less than 1%. Risk factors are common sense, really: diabetes, smoking, but also revision surgery and adjunct procedures. And within this, the authors highlight things like sliding technique and grafting surgery. In these 13 patients, they underwent phalloplasty, the vast majority being a forearm phalloplasty. Although the response rate to the satisfaction was around about 60 to 70%, the overall satisfaction of the surgery was 87%, which shows this is a viable option for those that have this terrible and unfortunate complication. In the second study, this is using a lightweight mesh for corporal reconstruction for those who've got very fibrosed corpora, which can't admit an implant. They're using a Ultra Pro mesh, which is a semi-absorbable type of mesh in 20 patients, and it seemed to be quite effective. 5% of these were explanted, though, due to chronic pain. And I think both of these studies really bring up issues regarding consent and also recording of implantable materials. So if we now look towards Peyronie's disease, we've only got one study in this. This is from Harrison and Nick Watkins' group. This is looking at length loss following plication surgery for Peyronie's disease. It takes them 100 patients who underwent plication surgery. Their mean curvature was 46.6 degrees. They reduced that down to 1.7 degrees after surgery. And they equated this that the mean length loss in the total group was 9 millimeters with a range of 0 to 20 millimeters length loss, which works out, if you plot it on a graph, they said that a mean length loss of 15 degrees is 15 degrees is 3.1 millimeters. And again, one of the really clever things about this and interesting things is that they identified a couple of patients within this poster whereby they had the same degree of curvature but lost quite significant varying degrees of length. And they postulate the theory that this may be due to the density of the plaques. So those who've got dense plaques, when you placate them, unfortunately, it doesn't really relax and you get compression. That's when you get length loss. Whereas those who've got malleable plaques, it's almost the plaque stretches itself out and adapts, and therefore you get length loss in these. And it'd be interesting if there would be a way to characterize these better in the future so you could predict this. And just in context of length loss, it's always a subject that's brought up when thinking about plication surgery and consenting them. And here is some of the kind of guidance of what patients might expect with their plication surgery. So EAU suggests about 50 millimeters. BAUS in its own consent forms suggests you get 10 millimeters per 15 degrees. The study we talked about 3.1 millimeters by 15 degrees, and there's also an equation that was put out there with length loss equals circumference times degree of curvature divided by 180. And if you use the characteristics above, which is a 30-degree curvature, although we wouldn't necessarily duplicate that, 120 millimeters circumference just arbitrarily chosen, these are the kind of length losses you may expect based on these, so 20 millimeters, 6.2, 20, and 15 millimeters. And I think this is really important in terms of thinking about consent. I like this poster because really it's real life data as opposed to equations or things that I can't find any references that support them. So I actually think it's really useful and important for consent. So miscellaneous benign andrology. This is a poster looking at the surgical management of adult acquired buried penis with concurrent lichen sclerosis. This is a 10-year experience. This is from Paul Anderson's group, presented by Hong. So it's 44 patients overall, BMI 37, with a range of 35 to 40. It's unclear exactly how these patients were selected and if they underwent any weight loss surgery beforehand. The vast majority of these underwent suprapubic lipectomy with a split thickness skin graft. Some of them did undergo full thickness skin grafts. The pathology at the end of these, though, I think, again, quite telling. 77% of these were lichen sclerosis, but 5%, so 1 in 20 people had precancerous changes or penile intraepithelial neoplasia. What does come out as a message from this, though, this is not simple surgery, and actually the complications were quite high at 50%. Most of these were kind of wound breakdowns and often resolved after time, but still morbid procedures. And those that had lichen sclerosis, 98% of them found they had no further recurrence after this surgery. So it was successful in the long term in managing their disease. If we take ourselves to penile cancer, we've got 2 posters in penile cancer. The first one here, just as a kind of precursor, this is looking at the evolution of sentinel node biopsy in penile cancer. And back in 1977, when it first really started, it was an anatomical dissection. But the addition of Patent Blue in 1992, Technetium-99, Metastable, and an ultrasound scan by Horenblass in 2001 really brought it into the fore for penile cancer management and gave it a kind of a fairly acceptable false negative rate of around about 5%, depending on which studies you look at. And people have tried to improve this further. And so, for instance, the addition of Magtrace, which is using iron nanoparticles, as opposed to using Technetium-99, so therefore hopefully removing the need for a nuclear medicine department, was presented back in 2018. And the future, no one really knows, but I guess one of these things could be the use of indocyanine green. And that's what this paper focuses on. So this is from Hussein Al-Najjar and Asif Minir at the UCLH group, and they've taken 21 patients. So in total, that's 41 groins. They've done their standard protocol for a DSNB, so they've undergone ultrasound scan prior to surgery with a SPECT-CT to identify the nodes and marking. Subsequent, they then had injection with patent blue and the indocyanine green. They found 63 lymph nodes that were excised. 97% of these were identified with the technetium-99, 24% of these with the patent blue, and 97% of these with the indocyanine green, which is really interesting. It brings in the question of whether we need to have patent blue in there. Does it really make that much of a difference? And I guess the question is also, can we replace the technetium-99 with the indocyanine green? However, it's worth examining the protocol a little bit on this one, because obviously they underwent the standard dynamic center node biopsy procedure, and it was the ICG was checked against that. So actually, the technetium-99 directed them beforehand. So I think it needs a little bit kind of further investigation. And certainly in obese patients, I worry that you wouldn't necessarily see it. And so I don't think we can get rid of the technetium-99 at this stage. There have been other studies in this, and more recently there's been a publication in European Urology in 2020. This was from the Netherlands. This is looking at, again, very similar, 400 patients, 740 groins this time, who had ICG and technetium-99. 1,325 lymph nodes were excised in total. 98% of these were identified by the technetium-99, 96% of these with the ICG. And when they looked at those ones that had patent blue as well at the same time, that's 492 groins in total. There were 900 lymph nodes excised, and ICG performed better than patent blue in visual identification of the nodes. That was statistically different as well. So the benefits of ICG, as I see it: no tattooing effect, which you do get with patent blue, less concerns regarding anaphylaxis as well, easier visualization detection of nodes, and there's no doubt about it. If you see the pictures, it's really remarkable and really highlights them, and it's relatively cheap. However, the concerns, I guess, would be that, can you reliably detect it through skin? Many of our patients are obese, and therefore you may not be able to pick it up. And where do you start your incision? So you still need the the technetium-99, and is it really giving that much of a difference? So in the largest, in the study from the Netherlands, their false negative rate remained at 8.7%, despite the addition of ICG. So is it really making a difference to our patients in reducing that? Final study here, this is from George's group. This was presented by Crawford. This is looking at what happens to those patients that relapse. It was 1,110 patients, so a huge number really. There's a credit to them for that. 244 lymph nodes that were positive, 73 relapses. And what this paper tells you is that patients who relapse do extremely badly, and they relapse early on. And I think what the suggestion at the end of this paper is that, should we be surveying these people more closely than in this period of time, which seems entirely reasonable. I guess the only question that we have to ask ourselves in there is, what are our therapies that we're going to offer them if we do pick up relapse, knowing that they do very poorly afterwards, and therefore are we actually giving a benefit? And that's open for discussion, I suspect. So in summary, penile implants, I think registries are here to stay, but in what format is unclear to me. Should we be consenting for penile loss as well on our consent forms? Peyronie's disease, should we be looking for a new model for counselling for length loss? I think that poster really kind of helps with that. Penile cancer-wise, I don't know, but does ICG have a role in management of non-palpable lymph nodes? I think that's still to be decided, but I think it's a promising and interesting area. And should we be following up patients more closely with positive nodal disease? And finally, for those who have got buried penises, should we be developing specialised services for buried penis or specialised centres due to the high complication rate for this? And that is it. Thank you very much.